I want to introduce our speaker this morning. She is Dr. Mary Jo Trepka. She's with the Department of Epidemiology at Robert Sample College of Public Health and Social Work, which is at the Florida International University. Perinatal HIV infection in Florida decreased from 38 in 2001 to 3 in 2011. We experienced an increase of 10 infected infants in 2014. This prompted the investigation by a dedicated group of public health providers and HIV/AIDS experts within the state of Florida. And Dr. Trepka will present the findings of this research today. The intent of this morning's presentation is that the results of this research will help improve the outcomes of perinatal HIV exposure in our state. And Dr. Trepka, welcome, and we'll let you take control.
Good morning, and thank you, and good morning, everybody. Thank you for participating. I'm glad that you're interested in this topic. I'm going to be talking about, again, what we found with respect to the transmission of HIV from mothers to infants in Florida. I do have a lingering cold. If I cough, I apologize for that in advance. I first of all want to say that I don't have any financial relationships to disclose, nor do actually any of my co-investigators. And I do want to spend a minute to thank everybody who worked on this project with me. First of all, from Florida International University, Dr. Sumati Mukherjee, Dr. Consuela Beck-Sagay, and from the Florida Department of Health, Lorraine Maddox, who helped us design this and get the data to us and do some abstractions. Again, from our Department of Epidemiology at the Florida International University, Dr. Fenny, Deanna Sheehan, Dr. Prabhakar, and Dan Thompson from the Maternal and Child and Health section from the Florida Department of Health, who's just retired, and Spencer Leap from the Florida Consortium for HIV/AIDS Research, and Danielle Mauk, one of our students here, who helped with this slide presentation, and Carolee Poshman and Ashley Tiller from the HIV/AIDS section at the Florida Department of Health, who helped to prepare the data set and did a lot of the abstractions. So what I want to talk about this morning is a brief background about how perinatal HIV transmission occurs, some of the measures that have been identified to prevent perinatal HIV transmission, the problem of perinatal HIV transmission in the United States and Florida. We'll talk about the data that we put together and our results, and then some recommendations. Okay, so I'm sure, as a lot of you know, that perinatal transmission can occur prenatally, during childbirth, and also during breastfeeding. So prenatally, it can occur because HIV is in maternal blood. Generally, the placenta can prevent against the exchange of cells, but particularly later in pregnancy, there's a risk of entry of the cells from the mother to the child. Also, during childbirth, the child can be exposed to cervical vaginal secretions or blood during delivery, and then HIV is in breast milk, so babies can become infected through breastfeeding too. The risk of perinatal transmission has been estimated at about 18 to 33% if the child is exposed. And throughout this presentation, I want to talk about perinatally exposed babies, and by that I mean the mother is infected with HIV and she's pregnant with the child. The chance of transmission is thought to be higher, about 40%, if the mother has recently acquired infections, and that's because we know that people who have a recent infection are likely to have a very high viral load. The good news is that if the recommended preventive interventions are implemented, including diagnosis and treatment and suppression of viral load throughout pregnancy, the chance of transmission has been found to be less than 1%, and that's been in some population-based studies, actually 2 population-based studies in Europe, where they were able to bring down the risk of transmission, that is, among exposed babies, to less than 1%. Now, in terms of breastfeeding, it's variable, depends on the length of the breastfeeding, depends if it's exclusive breastfeeding, but it's about 4 to 9%. Perinatal transmission is an important problem, and I'm sure you're all aware of this. I mean, for the child, this means the need for lifelong antiretroviral treatment. There's a potential for opportunistic infections and developmental delays, and potentially there's some social disadvantages too. And certainly for the family, there is the problem of the child's care and treatment being complicated. There's many expenses, potential loss of work time, and of course the emotional impact of having a child with this chronic disease. There has not been much done in terms of actually calculating the cost of perinatal transmission to society. There was one estimate several years ago about the lifetime cost being at least $270,000. I think that's probably a little bit conservative, and that estimate didn't take it only took the medical costs into consideration, did not take the cost in terms of the child's, the result of the child being, having a chronic disease throughout their life, and essentially the economic cost for the family and the child. So the national goal is to eliminate mother-to-child transmission. So there are accepted guidelines to prevent perinatal transmission in the United States. And the first part of that is screening, and that is that all pregnant women should be screened during the first trimester and in the third trimester in high-risk areas, and then to test at labor and delivery if the test result is unknown. Now, in the state of Florida, we have a law that says that all pregnant women should be tested during the first trimester and the third trimester. So in Florida, according to our law, we don't differentiate by high and low risk areas. We just say that all women should have both tests, first and third trimester, and also the testing at labor and delivery. Furthermore, the state statute requires that we essentially have an opt-out program. That means that the women are not asked if they want to be tested. Rather, they're said, okay, we test everybody. And the woman has a right to refuse, but actually if she refuses, the doctor is supposed to obtain written permission from her that she's refused. So that is the law that we have in place, which certainly meets or exceeds the recommendations of the United States. So the second part of prevention involves antiretroviral treatment if the mother is HIV infected. And again, the goal is viral suppression throughout pregnancy and during the labor and delivery and during the first 6 weeks of the infant's life. Then elective C-section is recommended if the maternal viral load is greater than 1,000 copies per milliliter, and breastfeeding is not recommended in the United States for women who are HIV infected because we have safe alternatives in terms of formula. So the CDC came up with a framework to talk about and think about how we can prevent perinatal HIV transmission. And I want to start with the right-hand side first, the prevention opportunities. And then we'll talk about the missed opportunities. And then when I present our results, I'm going to be doing it in this framework of the missed opportunities. So first of all, for the prevention opportunities, number one is to prevent HIV among women and girls. So decrease the incidence of HIV among women and girls, and thus the prevalence. Then the opportunity is to have adequate preconception care and family planning services with the goal of preventing unwanted pregnancies. That's the green area. That's before pregnancy. Then with respect to during pregnancy, having accessible, affordable, welcoming prenatal care, universal prenatal HIV testing and opt-out, as we have according to our law in Florida, and providing antiretroviral medication to everybody who's eligible. And then during labor and delivery and afterwards, using cesarean delivery if the maternal viral load is greater than 1,000 copies per ml, and also providing the antiretroviral therapy during labor and delivery, educating and supporting the women on avoiding breastfeeding if they're HIV infected, and then if the child does, and then after birth, that the child be given antiretroviral prophylaxis if the child is exposed. So then moving to the left-hand side of the slide, in terms of the missed opportunities, we're not looking at that. We didn't look at that in our study, but I don't want us to forget about them because that's really important. that we think about prevention of HIV in women and girls and getting people adequate family planning services. Then when we get to the pregnancy part of this, that women don't get prenatal care, or they don't get tested if they do get prenatal care, or they don't get adequate antiretroviral prophylaxis, and then during labor and delivery and afterwards, that if there's no cesarean delivery, even if it was indicated, and if the child is breastfed, and then if the child is not provided the antiretroviral treatment. Okay, so that's the framework that we need to think about it. Again, we were unable during our study to look at the green part of this, but it is also, but that part is, of course, very important too. So now I wanted to talk about what's been reported for the United States. So the CDC, this slide is courtesy of the CDC. It looks at the time period of 2008 to 2011. And this slide is a pie chart of the timing of maternal HIV testing among those babies that were infected. That was 327 during that time period in the United States. And you can say, these are infections, not all exposed babies. These are infections that the minority of them were tested before pregnancy, 23% during pregnancy, 10% at birth, and 19% after birth, and then 10% unknown. Okay, so this table is also from the CDC, and it's looking at timing of antiretroviral treatment for HIV-infected pregnant women. So now, again, these are not cases, but these are cases plus non-cases of exposed babies. Okay, and you can see that every year, if you look down at the total, that there's about 3,000 to 3,000 exposed infants. And you can see, now, if you start at the timing here, that there's three time periods that we're concerned about. First is during pregnancy, that's the first row. Second, labor and delivery, and then after birth. Ideally, we want an exposed child to have, during that pregnancy, that the mother would have gotten antiretroviral treatment during the pregnancy and during labor and delivery, and the infant would have received the prophylaxis. So if you look at that percentage on that second to the last row, DEP plus LND plus infant ARV, you see that about half of the exposed babies in the United States are actually getting that recommendation. So nationally, it's not ideal. So this next table is also the same time period from the United States, and it's looking at the exposed and the non-infected and the infected infants in the United States. And you can see that the overall, that 3% of the exposed babies, that's at the very last row there, who were exposed to mom who was HIV infected, 3% were infected, okay? Now, go one row above and you see if there was no treatment at all during pregnancy, labor and delivery, or childbirth, that the 13% were infected, which is really high. If you go up one more row, you see that if all three arms of antiretroviral treatment were provided, and we don't know if the mom was virally suppressed or not, but just if medication was provided, the 1.2% were infected. So that's nationally what was seen. So now I want to move on to Florida, since that interests all of us, and what prompted us to do this survey was what was going on in Florida. This slide comes to us from the Florida Department of Health, and it shows the number of cases by year from 1979 to 2014. And in one way, you can see this is just really remarkable. We've made remarkable progress since the early 1990s in terms of decreasing the number of perinatally infected babies. Because you look at 1981, 1992, we had over 100 babies per year. And then it dropped continuously until 2011. In 2011, that was the best year of all. There were only 3 cases of perinatal HIV transmission. But then the subsequent couple years, we saw an increase in the number of infections. The next slide shows not only the number of infections, that's the red line, So you see from 2007, 2014, there were 17 infections, 2007, 11, 2008. Again, it went down to 2011, but then it increased after 2011, 9 in 2012, 10 in 2013. What is important also is the blue line. The blue line are the number of exposed babies. And you see that that has declined continuously since 2007, which is actually very good news, that we have fewer exposed babies. So it went from 655 down to 500 into that 2014. But during that time period when we saw this increase in infections, 3 up to 10, there also continues to be this decrease in the number of exposures. Because of that, we wanted to take a look at what was happening, what had happened to both the exposed babies and the infected babies during this time period that led to this increase in the number of infections. So that was the rationale for our study, and the goal of our study was to identify missed opportunities to prevent perinatal HIV transmission. So this is a retrospective cohort study, meaning what we did is we looked at all the singleton births from 2007 to 2014 where the baby was exposed to HIV infection. And no, we didn't look at the multiple births sort of out of its simplicity. During that time period, there actually were no multiple births where a baby became infected with HIV. But anyway, so this study is about singleton births. So you ask, well, how do we know about who is exposed? So in the state of Florida, you're probably aware that we do have perinatal HIV surveillance. We have surveillance both of cases, but also exposures too. So babies who are born to mom who's infected with HIV, that's reportable, but on top of that, the staff at the Florida Department of Health link records regularly of women who are known to be HIV infected, who are in the state HIV/AIDS surveillance system, which is called EHARS, the Enhanced HIV/AIDS Reporting System. They link those records to the state birth certificate data set. If there's any potential matches, then they investigate to see if there was an exposure, a perinatal exposure, and if that was reported. So that's how we come up with this group of infants who were exposed perinatally to HIV. So what do we know, what do we have in terms of the data? So we have this group of infants who are exposed. We know some demographic information about the babies and the mothers too, both from EHARS and also from the vital records. We know about the mother's mode of HIV transmission. Did she, is it thought to have been through heterosexual sex or injection drug use, for example? From the report forms, we know about the timing of the mother's HIV diagnosis with respect to the child's birth. By that I mean, was the mother diagnosed before pregnancy, during labor and delivery, or after birth? We know about if the mom received antiretroviral treatment during pregnancy and labor and delivery, and also if the child received prophylaxis. We have information about the type of delivery, birth weight, gestational age, and I talked about the treatment, and then also breastfeeding. Now, the forms are kind of short forms. However, there is a space for case notes. The case notes, however, are not something that can be easily analyzed. And so what we did was we came up with an abstraction form for the surveillance staff to go in and pull out what we identified as potential barriers to HIV testing and also the antiretroviral medications. Now, these case notes were very complete where there was actually a case, that is, the child was infected, but essentially they were non-existent when there was only an exposure but no infection. So we have information about barriers for the cases where the baby's infected, but not the unexposed, the exposed but non-cases. Okay, then we classified the variables by birth weight and the adequacy of prenatal care. index that Katalchik had come up with in the early 1990s, which considers both when prenatal care began and the number of visits in all within the, considering the gestational age. We classified antiretroviral treatments. We used the classification system that for the treatment of antiretroviral naive women, and here I've got a list on the slide the different groups. And then we looked at the timing of the medications. Was it provided during the prenatal period? Was it provided during labor and delivery, or was it provided to the child? Okay, so then what happened actually was the Department of Health staff abstracted the case notes, and they created for us here at Florida International University a de-identified data set. So we stripped off all identifiers and sent it to us, and then we analyzed the data. What we did two types of analysis. This is a cohort, so we were able to look at relative risk, and we looked at both the risk factors for infection, because remember we have this pool of exposed babies, and we want to look at what led to infection. And then we looked at those factors that were associated with failure of particular prevention opportunities. For example, failure to identify maternal HIV infection during pregnancy or during labor and delivery, lack of antiretroviral treatment to the mothers during pregnancy or labor and delivery. And then we calculate relative risks and 95% confidence intervals. And our study was approved by both the Florida International University and Department of Health IRBs. Okay, so during the time period of our study, we had, which was 2007, 2014, this is the whole time period for which we've had perinatal surveillance in the state. There were 4,337 known singleton births. Of these, 70 children, or 1.6%, were infected with HIV. So, first of all, we looked at in terms of the risks of HIV transmission. It turned out that it did not vary by the infant characteristics such as low birth weight, or it also didn't vary according to the race ethnicity of the mother, but it was higher, significantly higher among children of U.S.-born mothers, and it also was higher where the mother's HIV acquisition mode was reported as sex with a male injection drug user. Now, it was not higher if the mother herself had an acquisition mode of injection drug use. It was only sex with a male injection drug use. So we really didn't see that many risk factors in terms of the characteristics of the mother or the child. Now, we also had information on the use of illegal drugs for the cases. And we also had information if the mother had developed a sexually transmitted disease during pregnancy. And again, this was only the cases. We didn't have this for where the baby was exposed but not infected. But I did want to talk about it because it's really, I think it's pretty impressive that 37% of those cases where the baby became infected, the mother had, there was a report that the mother had used illegal drugs during pregnancy, and 34% had a sexually transmitted disease during pregnancy. Okay, so in terms of the missed opportunities and the relationship to the baby becoming infected, no prenatal care was extremely, and I'm sure you're not surprised about that, but was highly associated with perinatal transmission. So the relative risk was 5.08, and it was significant. As you can see, the confidence interval was 2.6 to 10. Inadequate prenatal care, where the woman had some prenatal care but was not considered that enough, and this is utilization of prenatal care. This is not quality of prenatal care, which we couldn't assess. That was also associated with perinatal transmission. Late HIV diagnosis was also strongly associated with perinatal transmission. If the mother was diagnosed during labor and delivery, the relative risk was 5.7. In the postpartum period, that is, the mother is diagnosed after the baby is born, you see it's extraordinarily high, 26. So at this point here, we're seeing that, and it's not surprising actually, that these missed opportunities of lack of prenatal care and not being diagnosed with HIV were strongly related to perinatal transmission. We also saw that perinatal transmission was associated with lack of antiretroviral treatment during pregnancy with a relative risk of almost 12, lack of antiretroviral treatment during labor and delivery with a relative risk of 13. When we looked at the specific medications that the women received, it didn't seem to matter. And we don't have I don't think the data was really that good in terms of all the different medications they took and so forth. The timing, we looked at it kind of in a crude manner, but really what seemed to matter is did the women get it or they didn't get it. So non-elective cesarean delivery, that would be an emergency cesarean delivery, was also associated with perinatal transmission. Also, if it was unknown if the baby had received antiretroviral treatment or not, that was associated with perinatal transmission. And we didn't have anybody which said the baby didn't receive antiretroviral treatment. It was either yes or unknown, and I think some of those unknowns were related to the mother simply was not diagnosed yet, so I don't want to make too much of that. Breastfeeding was also associated with perinatal transmission. So this first part of our results really kind of reiterates what kind of we know, that all these things are important and they're related to HIV transmission. But now I want to talk about, what are those factors that seem to be related to these missed opportunities? That maybe there's some points of intervention here. Okay, so of the cases, 70 cases, again, where the baby became infected, almost 59% had inadequate prenatal care, and 19% had absolutely no prenatal care. That was 13 cases. Importantly is that 12 of those 13 cases used one or more illegal substances during pregnancy. Again, we don't have that information on only the exposed and the non-infected. We only have it for the exposed infected, but I think it's pretty striking that no prenatal care was pretty tightly associated with use of illegal substances. So in terms of not diagnosing the mothers during pregnancy, we had 984 cases of exposed babies where the mother was not known to be infected prior to pregnancy. Remember, our group is much larger, but that group, there were many women that the diagnosis was known prior to pregnancies. But we had 984, it wasn't known prior to pregnancy. Of those, 136 were not diagnosed during pregnancy. So that's 14% for some reason were not diagnosed during pregnancy. Those factors that are associated with lack of diagnosis included preterm delivery and very low birth weight, not surprisingly, inadequate prenatal care, and no prenatal care. Right? If you don't show up for your visits, prenatal care, it's unlikely you're going to be tested during pregnancy. I think we got some real insights when we started looking at those barriers that had been abstracted from the case notes. And what we found out was, these are just the cases now, of those, the 18 where there was no HIV diagnosis during pregnancy, 12 had at least one prenatal care visit. However, when we looked at the comments fields, for 10 of them, it seemed that they had an acute HIV infection. And the reason that we believe that is that they had an earlier negative test, and that was either during pregnancy. Actually, we even had some cases that were negative during labor and delivery, but tested positive after the child's birth. So it seemed like a lot of the lack of diagnosis wasn't that the doctors were never testing, but rather that the woman had an acute infection, and probably the test being used were unable to pick up the infection because the woman was in the window period. However, of the 10 cases that we think were acute infections, 5 of them did not have their last negative test during the last trimester. So for 5 of those cases, they were tested during the first trimester, but they didn't receive that second test, which is required by Florida law and is recommended in high-risk settings, which I think we can argue Florida is. So this is really a place where we can, I think, make some improvements here, because women are supposed to be tested twice during their pregnancy, and that didn't happen for 5 of these women. How many times it happened for just the exposed and uninfected babies, we don't know. I can only talk about the cases. Now, again, of the 10 acute infections, none of them, they were tested at a time when the 4th generation antibody antigen P24 assay wasn't available, and they weren't tested with an HIV RNA test at all, so it's very possible that they were in the window period, and for that reason they had a negative test. So in terms of not getting antiretroviral treatment, we had 4,215 women whose HIV infection was known about during pregnancy, and the factors that were associated with not receiving treatment were prematurity, very low birth weight. Again, this maternal U.S. birth, so the mother was born in the United States. No prenatal care is huge, which should be no surprise to you, and then, of course, inadequate prenatal care. What was interesting was that, as you see at the bottom there, the maternal perinatal infection, if the mother herself had been infected perinatally, that is, the mom was infected perinatally, and she's lived her whole life with HIV, that was actually protective for getting antiretroviral treatment, which means they got the antiretroviral treatment. It's probably because they've survived adulthood, they've been taking antiretroviral treatment, and they're in the system and so forth. So that was good news. So when we looked at the abstracted barriers, only for the cases, some of the barriers that we found were the women. There was a report that they had trouble filling the prescriptions. There's also reports of them not consistently taking the medications. There were reports of delay in the treatment by the mother. I have their incarceration. There were comments related to difficulties in getting the treatment, like in jail or coming out of jail. And then there were also comments about the women being fearful that their partner would find out about their HIV infection, or that them being in a denial. All right. Now, in terms of labor and delivery, so women are supposed to be if the HIV status is unknown, women are supposed to be tested during labor and delivery. Of those with unknown HIV status at the time of labor and delivery, the only factor that was associated with, for the mother, that was associated with not being diagnosed was the mother reporting having sex with a male injection drug user. Now, some of the protective factors that were associated with diagnosis were the mother being non-Hispanic Black, not having prenatal care and inadequate prenatal care, which makes sense because if the woman didn't get prenatal care, then her HIV status is probably not documented, and that is the indication for HIV testing during labor and delivery. So that all made sense. And in general, women who delivered in public facilities relative to private facilities, they were actually more likely to be diagnosed during labor and delivery if their infection was unknown at that time. In terms of antiretroviral treatment during labor and delivery, those factors associated with not getting treatment included prematurity, very low birth weight, again, inadequate or no prenatal care. Of the cases, there were 52 mothers whose HIV infection was diagnosed prior to delivery, and then 5 during labor and delivery. So 57% had a diagnosis. 57 women, 15 had no documentation of the antiretroviral medication during labor and delivery, and that included 4 women who had actually gotten medication during prenatal care. At first we were kind of surprised by this, but then we looked at the barriers, and then it was easier to understand. Many of these had a precipitous delivery and emergency cesarean delivery. I mean, they had notes like they were delivered within 10 minutes in the emergency room, so there wasn't really much of an option to give them the medication. There were 3 situations where the woman's HIV diagnosis was unknown to the delivery physician. It was communicated either by the mother or through the records. There was only one situation where the mother refused antiretroviral medication or an HIV test during labor and delivery. There also was one episode where apparently the medication was ordered, but it wasn't administered, and I don't know why, and it could have been due to the precipitous delivery. We don't have any details on that, but there was one case like that. Okay, and then in terms of, I think I'd mentioned before that for everybody, the baby had, there was documentation the baby received medication. There was nobody that said they didn't get antiretroviral medication, but there was somewhere it was missing. And many of the cases where there was missing, and that it was because the mother was diagnosed late after the child's birth. I think the breastfeeding information was important. As I mentioned earlier, of course, it wasn't associated with infection. There were 6 mothers whose baby was infected, who breastfed their babies, and 5 of these had an unknown infection. So had the woman known that they were HIV infected, then they probably wouldn't have breastfed their babies. And also, there were 13 women who were not diagnosed with HIV until after their baby's birth, and 5 of them breastfed their babies, which actually seemed to me kind of high. So again, if women are tested, then they would be able to make to be educated about not breastfeeding. So there's a lot of steps that I went through and a lot of different factors and so forth, and I just wanted to put this all together here. So again, we have these 70 cases where the baby became infected. The blue pie, our largest slice in the pie, are those the mothers were known to be HIV infected prior to their pregnancy and they were treated. Then we have this red group, which is the group where the mother was known to be infected prior to pregnancy, but they were not treated. And 7 of these, there was no treatment. 7 of these, there was absolutely no prenatal care. For some of the other ones, it was inadequate, but for 7 of these, there simply was no prenatal care. So that explains a lot of that red pie, that red piece of the pie. Then we had 8 where the mother was diagnosed during pregnancy and she received antiretroviral treatment. Then we had 3 who were diagnosed during pregnancy with no treatment, and the barriers for those 3 women included the woman was in denial, she's confused, she didn't follow up. Another one that said she was not compliant with medications and appointments. And the third one, she had tested positive the week before delivery, so practically it was at the time of labor and delivery. Then we have 12 who had an acute HIV infection during pregnancy, and 10 of these, and 2 of these actually had a negative test during labor and delivery and had a positive test after delivery. And I think this is important, those 2, because they were tested. They appeared to be tested only with a rapid oral test, but they didn't get a more sensitive laboratory-based test. Had they had a more sensitive test in addition to the rapid test, it might have been their baby could have been gotten antiretroviral treatment faster and been intervened on earlier. And then we had 6 other people who were diagnosed after birth. 3 of these had no prenatal care. So I did want to talk about our limitations. As I've already mentioned, we had a lot of information about our cases and very incomplete information about our non-cases, particularly about our prenatal care. We had a lot of missing values for prenatal care for the non-cases. We had no information about the barriers for the non-cases. And because this is surveillance data and it's just recorded kind of routinely by many, many people throughout the state, it's likely that there was collected, there's uneven quality of the data. But in summary, we had 70 cases among the 4,337 exposures. That's 1.6%, which actually is not bad compared to the United States as a whole. But it's still not. It's not where it could be. I mean, like as I mentioned, there have been 2 studies in Europe, population-based studies, large ones, who were able to bring down the rate to less than 5.5%. Late maternal HIV diagnosis appeared to be really the strongest factor associated with these cases occurring. And it seemed like the principal reason for these late HIV diagnosis and subsequent lack of antiretroviral treatment was the acute HIV infection and also the lack of prenatal care. So with respect to the acute infection, this is really very challenging. It's going to continue to be challenging as long as we have a relatively high prevalence of HIV within the state. And I think that the challenges are of the behaviors, the unsafe sex. It's hard to prevent transmission when women do get acute infections because of high viral load. And then the second problem is that you have a window period with acute infections that is getting smaller with the better tests that we have, but that still exist. And I think the recommendations that arise from this problem of the acute infections is that we need to be thinking about primary prevention of HIV and STDs, because remember there were a lot of STDs among the cases, among pregnant women, and that we need to be sure that providers are screening all pregnant women in the state of Florida during their 3rd trimester like they're supposed to be doing, and that providers are using the most sensitive tests available. And I would even go farther to say that, if you've got a woman that has unknown HIV status at the time of labor and delivery and she's had no prenatal care whatsoever, she should not only be getting rapid HIV tests, but also a highly sensitive laboratory-based test too, because first of all, there's not all that many of these women, and there's a very real possibility that she's HIV infected. So in terms of the lack of prenatal care, as I mentioned before, substance use appeared to be playing an important role in this, where 12 of the 13 women who had no prenatal care used illegal substances. And there certainly are lots of barriers for pregnant women who use substances, of stigma, lack of trust in providers, fear of child protection services, transportation, intimate partner violence, and coexisting mental health disorders. And this is probably one of the most difficult things to deal with, and I think it's going to take some ongoing discussions about how to deal with this problem. I think there would be a benefit of assessing what prenatal care services are available for these women. Look at maybe some best practices in other places, and to try to improve the treatment programs as much as possible. So, in conclusion, every case of perinatal HIV transmission is devastating for the affected child and the family, and certainly affects us as a community. I think we need to consider each case as a sentinel event and look at it carefully, and see what we can do to in the future to prevent any missed opportunities that did occur, so that we can move towards this goal of eliminating mother-to-child transmission of HIV. So, Millie, I want to thank everybody.
Thank you so much, Dr. Trepka. We have some questions that we'd like to go ahead and have the group listen to. Our questions that are on the chat are from Yvette Gonzalez, who is in Broward County, and she says that she has a question regarding the framework from the CDC. They don't add the extra medication that's given to the infant when the mother is new at delivery, or increased rupture of membranes that can also cause an increase in the possibility of an infected child. Can you address that?
Okay, yeah, no, I agree that's not there, and we also weren't able to look at that either with the data that we had. That is definitely something to consider.
Okay, and then she also says that she finds in 25% of the OBs in Broward County that they test in the first trimester, and when the results are negative, they don't always follow through with the third trimester testing. She said that it took the Florida DOH having a campaign called Protect Your Baby, Protect Yourself, to educate pregnant women about first and third trimester testing. And that is one of the roles of the Perinatal HIV Prevention Project, is to do education. And one of the reasons that we provide the webinars 4 times a year, and also do face-to-face education in hospital and clinical settings. So if anyone's interested in that, please contact me, because we will set up that education for you. Also, Yvette Gonzalez says regarding perinatally infected pregnant women that they are very difficult to keep in care and when they're supposed to be on meds and pregnant. And that our 2015 case, they had one that was perinatally infected and she refused medications, and the baby was positive, determined to occur in utero. I have to also say that as a perinatal coordinator myself, that was always among my most difficult patients. I know that your research didn't show that, but those perinatally infected mothers who were pregnant very often have a nonchalant attitude about staying in care and taking their meds. So I agree with Yvette's comment. Do you have anything to address that with? I know that your information ran a little contrary to what we found in practice.
But if I can address the testing comment first, and then the issue of
Sure.
where the mother is not taking her medications. So with respect to the testing, that 25%, that does not surprise me at all, given that we saw, cases where the women were not tested in the third trimester. I think that many people in Florida are not aware of how high our underlying HIV prevalence is in the state and how many new infections that we get. And I don't think people realize that there's a very real risk that a woman is infected and that she is, and she can even develop an acute infection. And I think that there's definitely needs to continue to be work done to inform the obstetricians about this. If you recall, too, that there was an indication, at least during labor and delivery, that the private facilities weren't as good at diagnosing during labor and delivery as the public ones. That suggests to me maybe there's probably some variability in providers' understanding of the risk of HIV infection in Florida, and there's probably needs to be some sort of enhanced campaign for providers in general about that. One, that the testing is of course required during third trimester testing, but that actually what the underlying reason for that is, and that the real risk that does exist in Florida. And then with respect to the third comment, but it was about difficulty in keeping women in care on meds. Yeah, I don't want to indicate that we knew the whole picture about any of these women. These were just case notes that happened to be written by the person doing the investigation, unrelated to our study, just during the process of surveillance, and what they noticed when they were doing their reviewing the records. And they would definitely not have all the information. So I can't say just because I had one case where they said they refused during labor delivery, there weren't other refusals going on. And I think there would be a benefit of, on an ongoing basis, really taking, doing a kind of extensive analyses of these cases of infection to really look at this in a more detailed manner, so maybe we have better information, we could address it in a better way. I disagree. I agree that this is just very difficult, and it's going to take a lot of discussion, I think, on coming up with maybe some creative ways on how to deal with these more difficult cases.
Thank you very much. And Yvette followed up with that she agrees, and that she also thinks that the OBs that are a bit older might definitely have the mindset. I see that as well. They kind of think they know it all, and they don't bother to participate in the education sometimes. She states that they visit all the OBs yearly to increase education regarding perinatal HIV because they seem to forget. And thank you so much for this presentation, Dr. Trepka. That's what Yvette said. But before we close, I will say that sometimes we offer education in clinical settings, and physicians are the first ones to opt out of attending that education for whatever number of reasons. And unfortunately, it does become a nursing responsibility to say, I know we have these orders, and that this is what we should do for in this event that we've identified a woman positive, maybe through rapid screening. And those are all factors that need to be considered. So we thank you so much. I hope that everyone enjoyed this and that everyone has a good day. Thank you.